already have received by email. And the other is the slides that I am going to use for our introduction in a few moments, in case you want to have them for your reference. So today's session is not going to be a full update on everything we know about coronavirus. And I hope I'm not going to disappoint anybody when I say that. If that's where you're hoping, you're probably in the wrong place. This is a Shawnee County focused session. So we really decided when the Shawnee County Medical Society, St. Francis, and the rest of our partners started to talk about this, we decided that it was time to bring our providers together from the county so that we can talk about our local situation and what are our needs, our gaps, and most of all, how we can address those gaps. So we hope that this will be helpful in making this discussion more relevant and more local. So it's really more of a local update with the goal of coordinating activities better in the future. We also hope, and Dr. Cooley, who has worked with me very intensively to prepare this session and this program today, Dr. Cooley will make some comments at the end to see how we can provide something that continues after this session, after this event in the near future. So unless there are some burning questions, I think I am going to start my program. And I think this may be the only slides you're going to see today. So hopefully they will come as a relief to you. This is not going to be a 3-hour program with slide after slide after slide. But my task in the next 10 minutes or so is to give you an update about the numbers in Shawnee County and the trends. And so it's hard to do that without visual aids. So this is where it all started. March 24th, we were being surrounded essentially by cases in counties, and it's really weird for me to go back and see that Sedgwick County had 6 cases back then, which seemed like a lot on March 24th, but I think our colleagues on Sedgwick County would pay to be able to go back to having 6 cases. But nothing was had been diagnosed in Shawnee County yet. Regardless of that fact, we decided that based on the epidemiology of what we knew about the virus at the time and the fact that it was spreading throughout the state, we decided that that was the right time to issue our safer at home order. And we did that on March 24th. And sure enough, on March 25th, we had our first cases confirmed. So our timing was really pretty much on target. And it's something that if we have time, we can talk about that during the day. We have based our decisions on what measures to take, what measures to lift on data. And the data before March 25th did not support for us to take a decision as drastic as a safer at home order, even though some people were pushing for that. And again, going back now from where we are now, it's hard to believe that there were people who were pushing, they were putting pressure on the health officer to be tougher and to make harder decisions and to impose harder precautions. We were following the data and we thought that March 24th was the right time, and I think we were right. Fast forward, and this is what happened since then. This is the number of cases reported to us by week, with the last week of reporting being the week before this current week. So the week that started on the 4th of October. The dates represent the first day of the week. These are cases reported to us as they come in. Couple of things, we started pretty low. We implemented our safer at home order back in March and in April, and you can see that our numbers stayed pretty low until the middle of April. That's when we started lifting some of the measures, and then the numbers started to climb steadily and slowly until the middle of June, when we had a sharp increase in that slope, in the slope of the curve. So they climb really increased considerably. What happened at the beginning of June? Memorial Day. Well, it happened, of course, at the end of May. But whenever we have these big holidays, and you can see in some other points on this chart, it takes a couple of weeks and then we see spikes in the number of cases. People were coming out of weeks of just staying at home, being essentially relegated in their houses, and they were tired, and the weather was gorgeous, and people came out and started to interact with each other more, and sure enough, the number of cases started to climb. So we reached what so far has been our peak of 225 cases in a week around the end of June. Let me tell you, 225 cases a week for Shawnee County is a lot of cases. We were totally overwhelmed. The health department was totally overwhelmed. At that point, we did not have any support outside of the health department to contact these cases and do a case contact investigations. And so everything was done by staff at the health department. It was all hands on deck. All other programs were suspended. We implemented a few additional measures, and the numbers came down until, again, middle to the end of July, when they started to climb again. What happened at that point? 4th of July, same story. Then the number came down in August until about the middle of September, the beginning of September. What happened then? Labor Day. So you get the idea. As predicted, the more people interact with each other, the more cases we see. Right now, we are we have completed the 4th consecutive week of increase in Shawnee County. Without counting this week, we do not know the numbers for this week yet. Another measure that's important to track is the percentage of positive cases out of all tests performed in the county. Our level of tests in Shawnee County has been pretty consistent and at a pretty good level for a county of our size, about 3,000 people a week. In many weeks, it's more than that. You can see that back towards the end of June and beginning of July, we had our peak of 9.1 positivity rate. That's pretty high. Anything above 5 is considered an indication of heavy community transmission. That number has come down considerably in July and August, particularly in August. Now it started to climb again, together with the number of cases that I showed you a moment ago. And last week, for the first time in several weeks, we exceeded the threshold of 5%. So a lot of transmission still going on in Shawnee County. Who are the people who get sick? This is the proportion of cases by race. You can see that, as expected, the majority of cases report being a white race. We have a 9% Black or African American, so that's not an excess number of cases if you consider the proportion of Black or African American in Shawnee County. The difference is minimal there. It's a different story when we start talking about ethnicity, though. We have a disproportionate number of people of Hispanic or Latino origin, 27%, more than twice their share of the population in the county. They have been affected by this pandemic disproportionately for several reasons. They hold jobs that puts them at high risk for infection. They live often in crowded environments. They often have jobs that don't allow them to stay home. And so when the rest of us was safer at home, they were still going to work. In terms of age distribution, this is the age distribution since March, so since the beginning. you can see that the bulk of cases occurred between the age of 20 and 65, so adults. We had a good share also of older people, but you can see the shape of the curve really almost like a bell-shaped curve, not exactly, but almost. This was since the beginning of March. However, if you look at the cases in the last 2 weeks, there is a shift here. So I'm going to go back. This is all the cases since the beginning. And this is the cases in the last 2 weeks. Of course, the numbers are different because we have fewer cases in 2 weeks. But if you look at the shape of this imaginary curve, you can see that we have more cases now in older adults, not the senior. I'm talking to people, 35 or older, and fewer cases proportionally in younger people, and very few cases in children and people of school age. So that's interesting from the epidemiological point of view, because despite the fact the school reopened, we did not see a spike in cases in those age groups. Hospitalizations, we had a total of 217 hospitalizations, and that is, sorry, that is 6.7% of cases diagnosed with a PCR test. So we have almost a 7% hospitalization rate in Shawnee County. And as expected, most hospitalizations occurred in older people, people who become more severely sick because of their age or other underlying conditions. Unfortunately, we had 69 cases of 69 occurrences of deaths in Shawnee County. These are provisional counts because all these deaths need to be verified by the Office of Vital Statistics. And as of yesterday, all but 22 had been verified. But we are confident that, unfortunately, the majority, the vast majority, if not all of these 69 deaths, will end up being certified by KDHE. So that's a case fatality rate of 2.2%, which I consider pretty high. If you think about, over 2% of people diagnosed who die, it's a little bit lower than the national average, and it's a little bit lower than the average in the state. Please keep in mind, this is a case fatality rate. It's not the infection fatality rate. So this is the proportion of people who are diagnosed with a lab test who die. And most people who are diagnosed with a lab test, we talk about that in Shawnee County, have symptoms, are symptomatic. This is the trend of deaths by week. We have seen an uptick in the last several weeks, primarily due to the spread of the virus in our nursing homes. And it is really something heartbreaking that made us very upset and very sad. We work really hard to keep the virus outside our nursing homes, and we managed to do that for several months. When the community transmission reached the point that was difficult to contain, then the virus inevitably spilled into our nursing homes, primarily brought in by employees who were not aware that they were infected, so they were also infecting other people. And so the result of that importation of the virus in nursing homes is seen here in the number of deaths that we have in recent weeks. How do we track all these numbers? We have a couple of tools that I want you to become familiar with. One is our community transmission scorecard. We release this every Thursday, and we distribute, we put it, we publicize that, we distribute to media outlets, we put it on our Facebook page. Many of you may already receive it if you are on our mailing list. If not, please send us an email and ask to be placed on the mailing list, and you will receive it every Thursday. And the reason I like this scorecard, I won't spend much time on it because we are running out of time, but we have a combination of 6 important measures that we tracked, and then we combine those measures into an index. And depending on the value of the index, we classify our community transmission anything between low, and uncontrolled, so green to red. And so you can see last week's scorecard, we were in the high zone of transmission with an index score of 11. We also have a dashboard on our website that's updated basically every day. And that's a snapshot of what's happening with viral transmission at this moment in Shawnee County. So it's very much focused more on the present. And we have already covered many of these numbers. We have a few challenges ahead as public health, and I think also as healthcare community in general. The politicization of public health is probably the one that, as public health official, concerns me the most. And I'm sure you all know what I'm referring to. When wearing a mask becomes a political badge, it's really hard for public health to do their job. And it's also hard, frankly, for people like you who are more in the basin of treating individual patients to do your job, especially when the politicization is combined with polarization, which means that we have lost the ability to talk and listen to each other. And we are just yelling and screaming at each other and nobody's listening. There is changing information and recommendation all the time. People in your position understand, I'm sure, that this is a new virus and we are learning something new every day. And to me, that's a fascinating part of my job, is to get up in the morning and see what's new today and what changed from yesterday based on the available evidence. But for the rest of the world, for the rest of our community, that is very confusing and leads to lack of trust in the ever-changing recommendations and the authorities that issue those recommendations. Virus fatigue, who doesn't have that? Who is not tired of hearing about this virus and not being able to hug our children, our grandchildren, our dear ones, or our elderly parents? And moving ahead, and that's really what brought this session together today, is the interaction between COVID and influenza in the upcoming months and the cold season ahead. Many of the activities that we were able to carry out in past weeks were done outdoors. But with the season changing, many of those activities will move indoors and people will start congregating indoors more and more. With that comes a higher risk of transmission. So that's all I have for now. Let me see if anybody has any comments that you want to make. We have just a few minutes that we can use for that, and then we will move on to the first panel. If you want to make a comment, please unmute yourself, and you are also free to start your video and make your comment or ask your question. You can also use the chat box, of course.
The school statistics are incredible.
In which way? Can you elaborate?
Well, yeah, I would expect that we'd have an increased number of younger people having COVID-19. I mean, the fact that it hasn't increased is just mind-boggling to me. I would just, with everyone going back to school, wouldn't you have more? You should have more cases. I mean, a lot more cases.
Thank you. That's a great comment. And we have talked about this at length. We will hear at the end of our session today more from two of our school superintendents. I can tell you already that they have done an incredible job in making sure that both staff, teachers, and students can resume schools in the safest possible way. Of course, there is a risk. We know that. We've never made a mystery of that. But based on those precautions, and probably also based on some of the biological characteristics of this virus, we know now that younger children are less susceptible to the infected. If they are infected, are less prone to become infectious, and they're less prone to develop symptoms, especially severe symptoms. We have had some cases of diagnosed in the school settings, but we have not have, get this, we have not have to date a single instance of transmission of the virus that we could document within the school setting. So we had cases diagnosed, but they were all, from what we can tell, acquired outside in the community, but not a single case of transmission in the classroom. I'm talking about the classroom, within the classroom. Other questions or comments? Okay, why don't we move then to the first panel, and I'm going to transfer now this to Dr. Dennis Cooley.
Okay, can everyone hear me okay? Well,
Yeah.
Thanks, Dr. Pizzino. That was an excellent presentation, and I think really important in getting that background for what's going on with COVID in our county here. So we're going to move now to the panel discussions. We've divided this up into various topics, and we've asked for representatives from our community facilities to be our panelists. I think we have about 20 minutes per panel. So I'm going to ask if each, and we'll go to each panelist and let them tell us about their facilities and what they're doing. I'm going to ask that.
Dennis, I'm really sorry to interrupt you. Dennis, I'm really sorry to interrupt you. There is a little disclaimer I need to make for the sake of everybody. I said that at the beginning, but not everybody was connected. We are recording this session, and we'll probably make this session public. So please be aware that anything you say may become public information. Thank you. Sorry about that.
Yeah, pretty important information there. Anyway, we're going to have about 20 minutes per panel. I'm going to ask the panelists probably limit to about 5 minutes each, and that way we can have some time for any questions or discussions. Our first community panel, or first panel is going to be on community-based testing. And our panelists are Dr. Miranda Fowler from Stormont Vale Health, Dr. Jackie Hyland from the University of Kansas Health System, St. Francis campus, and Zach Leaker, who's from the Shawnee County Health Department. So if all of you will maybe turn on your videos when you're ready to speak and make sure that you're unmuted. The first, and we'll start with Dr. Fowler. The areas that we maybe want you to comment on would be, what testing facilities do you provide? What are your requirements that you have for an individual to be tested? What's the best way that they can schedule that? What is the typical return time? And finally, are you planning on increasing testing in the fall and winter as this comes on? So I'll start off with Dr. Fowler.
Hear me okay?
Yes, very good.
Great. So our testing is centralized through our call before you go line, right? So 354-6000. It is not required that you be a Cotton O'Neill or Stormont Vale established patient to be tested for COVID on an outpatient basis for symptoms. When the patient calls, they speak with a nurse, and they're given a series of questions about their symptoms, date of onset, if they have a known contact, if they've been identified as a close contact through the health department and instructed to quarantine. If someone meets criteria for testing, so our criteria is one of the main symptoms, either fever, cough, or shortness of breath, or a combination of that and two of the lesser symptoms, sore throat, congestion, typical cold-like symptoms, then they're given the option to either be tested on a drive-through basis at our drive-through facility, which is located at 10th and Garfield in the parking garage, or if they feel like they need to be evaluated by a physician, then they're placed on the schedule at our respiratory clinic at the North Fielding location, which we'll talk a little bit more about when we get to the urgent care section. Our testing capacity right now for the outpatient basis at the drive-through, we're running anywhere between 100 and 150 symptomatic patients through there a day. It is in the parking garage, so we do have the ability to utilize that space to test fairly rapidly. Turnaround time has been anywhere between 3 to 5 days. Typically, we are getting the results of those symptomatic tests back into our in baskets at around the 48-hour to 72-hour mark. And then, of course, it takes a little bit of time to review those results and pass those results on to the patient.
Do you have any plans for increasing testing or adding in facilities at all?
As far as the testing only site, there's not plans at this time to add locations, although we do have some ambulatory testing capability on a limited basis at some of the smaller locations, Wamego, things of that nature. But we do have the capacity within the drive-through side and the parking garage itself to increase the amount of testing that we're doing through there. We have a small facility that has been erected in the parking garage itself that allows us to run 2 different lanes of traffic. And we have the flexibility within our nursing staff and the provider staff that's running that particular location to increase testing as needed on a daily basis.
And I assume that since you're having somewhat of an indoor facility, that when the weather gets bad, that's going to be a benefit to doing drive-through testing.
And it's outdoors, but we have been able to utilize the space with some modular type building materials and space heaters to keep our staff safe, but to allow the patients to remain in their car, which helps keep everyone safe as far as transmission, and also keeps the line moving fairly quickly.
Okay, thank you, Dr. Fowler. Dr. Hyland.
Good morning. Can you hear me okay?
Mm-hmm.
Excellent. Good morning, everybody. And thank you, Dr. Cooley and Dr. Bazzino for organizing this. This is, I think, amazing to be able to bring everybody together. So thank you. So answering the questions on the community-based testing for the University of Kansas Health System St. Francis campus. So our testing facilities currently, we have 2 that have been assigned specifically for testing. For our symptomatic patients, it's Brewster Ready Care. And so they call the Brewster Ready Care number, and it's open from generally 8 to 5 with some extended hours. And the numbers, 785-379-4600. And generally they will be doing the swabbing early in the morning, and they will schedule a test for the patient when they call, if they are a symptomatic patient. And we don't have real strict requirements for the symptoms, because of that asymptomatic carrier and some of the mild symptoms that can present. We're not being really strict. Really, the most important thing is they have a order from their physician that is faxed over, and Brewster can supply that number for the fax to the physician office if they're coming from another area. If they are a new patient, then we would register them, and the provider would do an assessment, either via telemedicine, or if they do need to come in, they would bring them into Brewster Care with appropriate PPE. So that is one location. We do have a second location at the Imaging Center over at 601 Corporate View Drive. And that's for any asymptomatic individuals who are requiring testing for a variety of different situations. We do that for our surgeries, for some procedures that are done. There's also, we're getting lots of calls from different schools as kids go off to college, needing testing before they go, before they travel. So that is a testing location where you do not need to have actual symptoms to get tested. You still need to have an order from a physician to get tested at the imaging center. And we're using a variety of different, testing agencies. We use, LabCorp, we use AREP. We do use the main campus, the University of Kansas Health System's main campus to test. That's one of the things that they have set up since the pandemic started. They have never been an organization that's had a reference lab, so that's been very interesting to work with them. And there's a lot of hurdles that you have to get over starting a new reference lab, but that's going well. One of the important things we found in the pandemic is to diversify where your resources are coming from. So we have multiple different companies where we're getting our testing supplies, from BioFire to Quidel to the health system, and also continue to use the KDHE's lab as well. We are starting to, increase our capacity for testing. Sometimes as we got a lot of the calls as people are traveling a bit more, going off to college, using the antigen test. And there is some guidance with that from the CDC, as the rate of infections go up in the community, the sensitivity or the, correct negative test, that sensitivity goes up. But if you don't have, if you don't have a lot of infections, then there's the worry whether the antigen test really is catching true positives and catching those that might have, be at the very beginning of their, if they've just become infected. So we do have the recommendation, if they test negative and they have been exposed to somebody who is positive or start having symptoms, to get retested, either with the antigen test or the PCR. But the PCR test does continue to be the gold standard. But with the concerns moving forward into the flu season, as we have more individuals with respiratory symptoms and using more tests around the country, if there does become a shortage, we do have a significant supply of the antigen test, and that is a pretty quick test that we don't need to send it off to a lab. There's no reagent. It can be done on site. And it takes about 15 minutes. It's just not quite as sensitive as that PCR test. So that's our plan to increase testing as we move into the flu season. And our BioFire, has the full respiratory panel with both for the SARS-CoV-2 that causes COVID-19, and has the, all the other respiratory viruses on there as well, including both influenza A and B.
So if you use the antigen testing, we're using those. What are the sites, the two sites that you have currently, are that where you're going to be using your antigen or possibly using the antigen testing? Possibly
using the antigen testing. We'll use it out at the imaging center, depending on what the requirement is from the institution that they're going to. Some of them will accept the antigen test, some of them will not. So, but for patients who are diagnosed as they're coming into the hospital, we do require that PCR as the gold standard to make sure, that we identified it correctly.
Okay. Thank you, Dr. Hyland. I might go back just once to Dr. Fowler. You're using all PCR testing, correct?
All of our testing is PCR at this time.
Yeah, thank you. All right, let's hear from Zach Leaker from Shawnee County Health Department.
Yeah, hi everybody. My name is Zach Leaker. I am typically the health promotion coordinator during normal times. COVID times, I am a testing branch director. So currently our site is located at New Mount Zion for drive-through testing. That is a community church we've partnered with to allow us to use their building, created a contract so we can fit, putting about 50 people through a day is our capacity. And we're doing that twice a week on Tuesdays, Thursdays for a total testing capacity of 100 a week. We could easily expand that to multiple days or longer hours. We have the staff and capacity to do that. We just haven't met the needs to expand yet. We're hoping we never have to, but we easily could. We are running primarily PCR tests, and that is through the KDHE lab. Since we're running through the KDHE lab, we're running through their KDHE requirements and guidelines, meaning the 2 symptoms, and we have about a 24 to 48 hour return on results, and that's including the notification process as well. We do have the ability for asymptomatic testing with prior approval, depending on Dr. Pizzino's guidelines. So we do have the ability to do strike team capabilities, which we have done in the past, and I won't go into specifics. But we do know if there's certain locations with clusters, we can send a specialized team of health department staff and nurses to go there to collect samples to kind of gauge what's going on in a certain location. So we can do that as well, and we have a couple times. Primarily, we're focused on the uninsured and underinsured population that is being missed. So that's basically our goal here. We have so far administered through our drive-through testing clinic 608 tests with 126 positives coming from that, which is roughly about a 20 to 21% positive rate, which is much higher compared to the national averages for the numbers we can pull. So I'm glad we're addressing the gaps that need to be addressed.
Zach, how many can you run through in a day, do you think?
So in a day right now, if we were to stick to our hours, which our hours are Tuesdays, Thursdays from 8 a.m. to 11 a.m., that is going to change later this month to 11 to 2 as the temperatures get a little bit colder, try to keep our staff a little bit warmer and more daylight. At 8 a.m. it is now dark. But we can do about 50 a day if we stand by our 3 hours. And so that's looking at about 100 a week. We could, like I said, we could easily expand it in multiple hours. We could also put up a second lane. We could do all kinds of different things. If we needed to fit 100 people through a day, we have before and we could again. If we needed to do it 3 times a week, we could easily do that. If we had the capacity that said that we needed to do 4 to 5 days a week, we could work with it. So we're just trying to meet the needs of the community right now. Yeah, absolutely.
I think we have maybe some time for maybe one or question or 2 questions if anyone has one.
I have a question. I would take moderator's prerogative, even though I was not the moderator for this panel, but we haven't really talked about payment. And I was curious if we could hear from Dr. Fowler, Dr. Highland, because we know that the health department doesn't charge. So if people get tested through the health department program, there is no charge. But how do you handle insurance and payments? And are there instances where maybe there is no charge for the test, but then there may be a charge for an office visit or an administrative fee? Has that been a barrier? What can you tell us about payment?
So at St. Francis, we are not charging the patients for the test. We will charge, we will send it through insurance. And if they do require a visit, either telemedicine or in person, then their insurance would be charged for that. And then whatever the copay would be for that as well, but not actually charging the patient for the test. And I believe that may, change at the beginning of the year with some of the, the CARES Act changing, but nothing official has been discussed or decided.
Dr. Fowler, I think you're muted. Yeah.
Get myself unmuted. Across the board, when patients call in for testing, they go through the pre-registration process, so their insurance is verified. If they are uninsured, they are able to come through the drive-through testing. That visit is documented and coded as a nurse visit, so it's not, unless for some reason, the physician that is attending that day needs to go out and do an exam in the car for whatever reason. If the nurse identifies that they're in some sort of distress, then there is charging on the backside for a physician visit. That's a little bit different for our those that are tested through our respiratory clinic. That is set up like an urgent care visit and goes by the same standard that we use for our urgent care visits for uninsured patients, that has the cash fee copay up front, but that's for the visit itself, and then the testing falls under the CARES Act guidelines. But as far as going through the drive-through testing, a copay or anything up front for those, but they are billed on the backside as a nurse visit.
Okay, thank you. There's one more question that was in the chat box, and then we'll have to move on. Dr. Hyland, the question is, what is your capacity for testing? I assume that means numbers per day.
Yeah. So our, I don't think we have reached complete capacity quite yet. We're probably at about 80 tests per day with both the symptomatic and asymptomatic testing. And we probably could, double, if not triple that. I think, what would become the concern is the testing supplies, but currently we have at least 2 to 3 weeks of testing supplies.
Okay, thank you. And I want to thank the panelists, Dr. Fowler, Dr. Hyland, and Mr. Leaker for attending the panel. So let's switch now to our next panelist. That's going to be on outpatient services. Our panelists are and I apologize if I mispronounce anybody's name, Dr. Mark Sankarikal from the University of Kansas Health System St. Francis campus, Dr. George Wright from the Cotton O'Neill Clinic, and Venus Lee from Grace Med Health Clinic. And the questions I'd like to, or the areas I'd like our panelists to discuss would be what hours your facilities now have available, what services are you providing? For example, preventative care, maybe some non-urgent illnesses, immunizations, and what are you doing to prepare for the fall and winter season? Dr. Sankarikal, could you maybe start us out?
Sure, absolutely. So my name is Mark Sankarikal. I'm one of the internal medicine doctors here at St. Francis in our primary care clinics. So a few things that we're doing as we head into flu season, primarily, of course, are flu shots. And there's several ways that we're providing them to our patients who are definitely more motivated this season, maybe than before, to get their flu shots. And so, of course, at regular appointments, we're offering flu shots with any regular visits. But beyond that, at our Mission Woods Clinic at 20th and Urish, we have drive-up flu shot clinics as well. And then all of the primary care clinics have offered kind of designated flu shot clinic hours. We're having patients call in, they'll schedule a time and say, come in at this time, you can come get your flu shot without an appointment. And we're staggering those so we don't have a large influx of patients in the clinic at the same time. And then our Ready Care Clinic over at Brewster is giving walk-in flu shots without an appointment as well. And as Dr. Hyland had mentioned, the Ready Care Clinic's hours are a little bit longer, 8 to 7 p.m. Monday through Friday, and then Saturday, Sunday, 10 to 6 p.m. So the ability to get flu shots is definitely there for our patients. As far as patients calling in with symptoms and requiring COVID testing and things of that nature, with the rapid testing that Dr. Hyland had mentioned, if patients are calling in and have symptoms that we are concerned about for COVID, we can get the rapid testing done and have results in a couple of hours. And then the providers, once they get notified of the result, can make their determination on how they want to proceed, whether it is bringing the patient in to be evaluated, doing some telemedicine visits. We're also establishing a kind of a respiratory clinic location currently at the Ready Care Clinic, but starting in November, that'll move to our Mission Woods Clinic to kind of deal with patients with those kinds of symptoms. And as far as testing goes, as we kind of already mentioned, currently the patients will call their provider if they say they have any symptoms and are deemed appropriate for COVID testing. The provider orders the COVID test. The patients go to our Brewster Clinic location at 29th and Topeka. They swab them in their car, and then the provider is notified in a couple hours. And then, but if the patient ends up in our clinics for just a sick visit, and at that time the provider decides, oh, you meet the qualifications for getting a COVID test, all of our staff in the clinics, the regular primary care clinics, have the ability to do the swab while they're there. And so even then, patients without any primary care physician providers can receive swabbing by calling our toll-free number and can get testing that way as well. And then, as Dr. Highland had mentioned, for asymptomatic patients, whether it be for surgical reasons or exposure, et cetera, our imaging center is having, as a walk-in basis, you can get tested. And then in the same way, if you have a provider, you can call them and we can order testing for asymptomatic patients and direct them where they need to go.
In all of your outpatient facilities, you're still doing all your normal preventative care, no cut back on any of that like we had on when we first started.
Right. Yeah. So our numbers are getting pretty close back to normal, and we're having patients come in. We obviously are using, extra precautions. Our waiting rooms are separated, or, social distance. We have plexiglass, so everyone has to wear a mask, all the things that we should be doing. But we're still encouraging patients to still come in if need be, or use telehealth. But we don't want them to not feel like they need to not get the care that they're accustomed to.
Sure. And have you guys expanded your telehealth programs?
Yeah, so it's definitely become, I would say early on, we definitely were using it a lot more. I feel like now patients are more wanting to come in as opposed to using telehealth, but we definitely have several programs that people can use. Our providers have used, different services, Doxy or WebEx, and whatever we can get the patient to have success to connect with us, which really is usually the first barrier, is getting our patients to connect properly. But once we kind of work with that, staff is we've kind of learned as the process has gone, and I think we've become much more efficient.
Very good. Thank you. Dr. Wright.
There we go. Good morning. I've been so impressed at how our communities work together to address this challenge. The coordination that I've been seeing here just expressed this morning is impressive as well. Our facilities have provided a number of different venues to do testing and treatment of patients with symptoms of COVID, as well as to provide for testing and for flu immunizations. Just to kind of go through a list of those, we are providing drive-through clinics for flu immunizations each Wednesday through October. This is coordinated with our testing for COVID that has taken place at the same location that Dr. Fowler described, and is being, the numbers are being addressed by expanding that as needed. We've briefly touched on our call before you go and our COVID hotline, which helps to direct our patients to the proper care facility, whether it's our respiratory clinic that's being held at our North Fielding location, where patients are directed for illness. If patients have minor symptoms, they're tested through our drive-through testing at the parking garage at Stormont Vale. If patients are deemed at any point through there to be severely ill, they're either sent to the emergency department or for minor symptoms to our North Fielding clinic. As we anticipate expansion of or increasing in numbers, we're opening new respiratory clinics, one to start at our Mission Woods location in mid-October for pediatric patients, and to be expanded for adult patients in mid-November. That sort of addresses our locations and timing. We touched a bit on, Dr. Sankourkal talked a bit about how they're addressing primary care services, and we're doing much the same. We are providing the same services that we did before. And I think I might just mention some of the challenges of that. We are screening people through our appointing process with a list of symptoms that might be attributed to COVID at our front door, at our front desk, and in our exam rooms. And at any point during that process, we're directing patients to the most appropriate site of care and employing the proper protective equipment at any of those locations. As a primary care doc, it's been a challenge, I think, to address some of the fears that our patients have expressed. And I think the Shawnee County health officer and health department has done an awesome job at giving us accurate information that's pertinent to our community. Our website and has been kept up to date, giving us numbers of cases, the facilities that have been provided, and kind of how we're dealing with our PPE, our number of hospital beds, ventilators, et cetera. And in our exam rooms, I think we have to do our very best to encourage our patients to receive their immunizations and to carry on proper care. What we've tried to do, and I think our community has tried to do this as well, we've tried to make our offices, our primary care facilities, our referral services, our specialty offices all as safe as possible by utilizing our call before you go, our hotline, to direct patients to our respiratory clinics so that those who are most likely to have COVID-19 don't enter our primary care and specialty services facilities. And then leveraging our relationship with our patients, trying to reinforce, encourage people to use masks, to use care for one another, care for our elderly, trying to put the politics aside to care for one another. That relationship that we have with our patients within our community is very important in all that. So any other thoughts?
Well, let me have Ms. Lee talk to us, and then we'll see if there's any questions for people. I think you're on mute.
I apologize.
There you go.
As you know, we have two, and you may not know, we have two locations in Topeka, Kansas, our capital location, which is at 1400 South Pontoon, and our Highland location, which is at 2025 Southeast California Avenue. Our hours of operation is from 8 to 5, but at our capital location, we do have a little bit of extended hours. On Thursday, we start that clinic at 10, ending at 7 p.m. We've already started gearing up for the flu season. We are currently doing flu shots. We do allow people to walk in. We prefer that people make appointments. We do offer flu shots at every single visit at this point, just so that we can do our part in keeping the community covered. Right now, we use our community partners to help us with COVID testing. We do take measures as far as screening measures via phone and via when they come in to the clinic. There's some screening procedures we do, taking temperatures, making sure that all of our staff is required to wear a mask. We also require our patients to wear a mask. We provide patients with a mask if they come in without that. We have always done what we could to continue on with our preventative care, breast exams, PAPs, tobacco cessation, weight assessment counseling, but also with things like diabetes, hypertension, asthma, heart disease, depression, behavioral health. We've continued to keep those services going. It is interesting, somebody did mention the fear of the patients and to come into the clinic. One of the things we did start offering a few months ago was the telehealth services, and that has ramped up a little bit over the last month, but because of our demographic, a lot of our older patients had issues with the technology piece of it, so then we put a component in which allowed us to do a pre-visit the day before the actual visit. So those things take time, but we've recently, and when I say recent, everything is running together. In the last 3 months, started training all of our medical providers on utilizing the telehealth services. So that's some of the things that we're doing on our part to help out the community, which has been wonderful collaborative partners.
Have you seen more of an uptick of your people coming in for preventative care, especially say over the last few months, especially when COVID first started?
Yes. Before, most patients, we had a really big drop in patients coming in for preventative services. And then you had the fear factor, because even when it was appropriate to come in, or we say appropriate, we had patients who were still scared. But a lot of times now what we do is we utilize our call center and our community health workers to pretty much get in touch with those patients to let them know how important it really is to come in now for your preventative services, so that preventative service don't turn into an emergency service. So we have seen some uptake, and even with telebehavioral health, we'll do those services, but we still need to explain to patients who, for instance, a patient who has diabetes who need to come in for lab work. I mean, that's something that we can't do through telemedicine, telehealth. So we're doing our part in outreaching to those patients to see if we can get them in.
Thank you. Questions for people?
Yeah, Mrs. Lee, I have a question. What do you do if patients need a test? Because most, if not all of your patients are uninsured or underinsured. So is that a barrier? If they need to be referred for a test, what do you tell them to do?
Well, we have a list of our community providers who provide tests, like Zach said, for the health department, and we send a number of patients to Stormont Vale. So it hasn't become a barrier yet, and we, as you may or may not know, we do a great deal of testing in Wichita and do a drive-through testing here, and so we have looked at a possibility of what we could do in Topeka, but we've had really good collaborative partners in Topeka, so we really haven't had to go that route, and they've been really receptive, and really the timing has been good in when we get our results back, say from Stormont or the health department. So they've been really good partners, and we haven't hit a wall at this point.
Other questions or comments? Okay. Well, thanks to all the panelists again. We'll move on to our third panel, which is concerning urgent care clinics. We really only have one panelist in this section, and that not because we didn't try to reach out to a number of our urgent care partners, but scheduling issues and some things came up, and so there was some unavailability. But I did talk to and look at a lot of our urgent care clinic facilities, and so I'll talk a little bit about that too after Dr. Fowler gives her comments. So what we kind of would like to know on this is, first off, how many, I'm sorry, Dr. Miranda Fowler is with the Stormont Vale Health Systems. Number one, how many facilities are available that you have? What are your hours? Are you planning on making any changes as far as hours go? Services that are provided at your facilities, and what type of limitation to the patients, for example, insurances do you have in your facility? So Dr. Fowler, would you like to start?
Sure. Okay. So Stormont Vale, Cotton O'Neill, Express Care, our urgent care facilities typically would have 5 locations. Our corporate view location up at the Tall Grass Building is currently not being utilized as an express care location as it has in the past. Those resources have been diverted to the drive-up testing clinic. So the nurses and the physician resources are now being utilized for that instead. So at this time, there are 4 urgent care locations as well as the drive-up testing site. 3 of the sites, Southeast Croco Road and 29th, Southwest Urish, and the Midtown location at 909 Mulvane are non-respiratory or non-COVID PUI clinics. So anyone can present to those 3 with non-COVID like injury or illnesses, just as they normally would prior to the pandemic. Hours are still the same, 9 a.m. to 8 p.m. On the weekdays, 11 a.m. to 5 p.m. on the weekends. When they get there, they are screened. So should they screen positive to any of the screening questions that would make them concerned from the door screeners that their urgent issue is actually a coronavirus-like illness, then coordination occurs at that time to provide the patient with an appointment time at the North Fielding location or the respiratory urgent care. So there are 2 avenues that lead you to the North Fielding Respiratory Clinic location, either if you screen in positive by presenting to one of the other locations or through the COVID hotline call before you go. We are encouraging patients who need any sort of care to call before you go and get placed on the schedule for the respiratory urgent care clinic at 46th Street. The hours there are similar. Start seeing patients at 9 a.m. Due to the confines of the massive amount of PPE and cleaning of the rooms and the turnover and whatnot, we do stop seeing patients there an hour earlier at 7 p.m. And because we're trying to control the flow of patients, those are appointed visits. So it's still available on an urgent same day basis. That particular location has been functioning pretty close to full capacity, 75 to 80 patients per day over the past week or 2. We, as Dr. Wright mentioned when he was speaking of our primary care plans, we do have plans in about a week and a half to open a second location primarily for pediatric patients that will take some of the burden off of the North Fielding Respiratory Clinic to open up more spots in that facility with the intention that the second location will then also add an adult available physician to be available for families. Weekend hours at the North Fielding Respiratory Clinic are the same as the other locations, but ending an hour earlier there as well at 4 p.m. As far as utilization of resources, very similar to what our urgent care, express care utilization has been in the past. When they register, if they have insurance, their insurance is billed. Any copays that are required are paid at the time. If they're a cash pay patient, they require an upfront $30 fee to be seen on the day of the visit for all locations. And then they receive any additional billing that is left after the visit.
I'm sorry, did you say, and Medicare and Medicaid?
Yes, absolutely. Yeah.
How do you manage if you feel like in your urgent care clinics that a patient needs admission?
So we are able to utilize through our physicians' health connections direct admission through the hospitalist teams, both for pediatric and adult patients. We also have good working relationships with other subspecialties as well. So if we have anyone that we feel like needs admission from the clinic, it's a fairly seamless process where we're able to speak directly with the admitting physicians and get them directly admitted out of the urgent care.
Very good. Thank you, Dr. Fowler.
Yeah, sure.
Let me kind of give a little bit of a summary of urgent care clinics that, at least from some of the things that I've found out. Besides our express care, we have at least 9 other urgent care clinics kind of throughout the city. There may be more. These are just the ones that I could find. We also have private providers who may be offering some urgent care type of care. I'm going to briefly mention pediatrics here. We have one pediatric urgent care, and that's Kids First Urgent Care Center. And then apparently we're going to be having a second PEDS now urgent care center from an Express Care. My office, or my older office, Pediatric Associates, used to have we ran a walk-in clinic for urgent care for just our own patients. And we did that prior to COVID. We were, it was basically 9 to 4, and on weekends, we did some weekend time, but that changed after COVID, and it really became a respiratory clinic for our patients. And so, and that still is right now. There are not weekend hours, but what they are seeing is it's scheduled. It's not a walk-in. It is the respiratory clinic only. And if they do have a patient or a child who not only is symptomatic, but has a positive exposure, then they are sending those or scheduling those up at the North Clinic of Stormonts too. There are the urgent care, that's just a little brief summary of pediatrics. Urgent care clinics are scattered throughout the city, but there's only, I think, a couple in the north, maybe one on the east side. Most of them are really located central and in that southeast area. We also have one retail-based clinic through Walgreens. Our urgent care clinics hours vary. They're pretty similar though. Some of them, most of them throughout the day, obviously, work days, the week, or during the week, work days. Some of them will go till early evening, maybe 8 o'clock, but the vast majority that I could tell were finishing somewhere between 4 and 6 p.m. Weekends vary, but they tend to be a little bit shorter, either starting later and even ending a little bit earlier. All of them seem to take private insurance, although not all private insurance. It probably varies depending on the company. Most will take Medicare. A few will take Medicaid, but that's a bit of a problem, it seems like, in getting Medicaid to be accepted. And most obviously will do minor urgent care type of care with x-rays, some laboratory. Whether or not they're doing COVID though in the urgent care center is hard to find out. There's at least one I know of that says that they are. I assume that, well, I don't know. I can't tell what that is. Couldn't tell. And then the last one that I'll kind of talk about is sort of it's the Topeka ER and hospital. In their chief medical officer, Dr. Jared Schreiner, he couldn't make it today, but he was kind enough to send us some information and on the questions that we asked. They're really probably more of an ER type setup rather than an urgent care clinic, but obviously they would be functioning as an urgent care also. They are open 24/7. They will, obviously they have some testing capabilities. They also have imaging capabilities. They will do some community testing and some community laboratories if you send them a doctor's order, although they did say all other testing is done through an ER visit. So unless they have an order, I think that they would have to go through their ER, which makes sense. They do also have a 6-bed inpatient unit, but no ICU capabilities. So for serious respiratory patients, it sounds like they would have to transfer them. They are also working on protocols with our local disaster management services, and they are doing COVID testing there. They do in-house. They're doing the Sophia rapid antigen test. And they said they've gotten a Abbott ID Now, which is a rapid molecular test. And they can offer at least getting the specimens for PCRs and then sending those off. so that's kind of a summary of the urgent care situation in the county and in the city. And I will open it up now to see if anybody has any questions.
Dennis and Dr. Fowley, what's your sense, combined sense about the surge capacity that the system is going to need and the system is going to be able to afford in the upcoming months?
I think that, I don't know, I'll be honest with you. I'm not sure that we're going to be seeing a significant increase in the hours and in the availability that's going to be present. The issue that I see is the same as Dr. Fowler mentioned and Dr. Wright and everybody mentioned, is that like what they have with their North Clinic, is that when you're seeing these respiratory patients, because that's what I did for a while before I was still with Pediatric Associates, is that it takes time. It takes a long time because you have to put on PPE. You can't, and plus, I think it's an issue with walk-ins because you just don't want to have those waiting rooms full of people. And so I'm a bit worried. I'm glad to see that we're opening up more respiratory clinics, but I'm a bit worried that there's going to be a difficulty with surge.
Yeah,
especially
I would agree that it's a little bit concerning this early in the fall to already be near capacity at our North Fielding location. It is promising, though, that we do have the ability to move to add an additional location with potentially the ability to flex our other urgent care locations, combine the non-COVID like illness patients to, we have a lot of locations to work with. But I would agree that the time that it takes to adequately protect yourself with PPE and then adequately decontaminate the exam space, it's not as rapid of a turnover. And currently we're functioning with a parking lot waiting room, which I think has helped some, but that also takes time. So the patients have to call the registrar to let them know that they're there, and then they're escorted in one at a time to avoid the waiting room. And it really does add, a good 5 or 10 minutes on either side of the visit, where normally we would be able to process people through very quickly in an urgent care setting. It has definitely caused some challenges for us on how to get those patients through efficiently and take care of the patients that need to be seen.
And another issue I see is, I think if an urgent care clinic does get somebody that they think needs to be admitted, I think that makes things a little, with COVID now, that makes it difficult. I mean, where, it's, where you're going to send them, how you're going to send them, the respiratory clinics, I think, have it set up nicely, but I'm not sure that our urgent cares do, and how they're going to manage that.
Yeah. And, at least from our perspective in our facilities, if someone does make it, past the screener, we have noticed a propensity for patients to sometimes maybe not be completely honest with their presenting symptoms to those door screeners. And so sometimes people do make it through in our non-respiratory clinics back to see the physician when they actually do have some COVID concern, but we are adequately prepared with the appropriate PPE. And so then at that point, it just becomes a respiratory visit in a non-respiratory clinic. And we're able to get, if that patient did need to be admitted, to go, through our direct admissions. But I would agree the surge is concerning.
Yeah. Dr. Highland, I don't want to put you on the spot, but maybe you, with your Redicare facility too, you mentioned that I think is becoming somewhat of, or a respiratory clinic too, or is that right? Could you maybe?
Yeah, Kurt. Yeah, if patients are calling before they come, then they will be, diverted over to Brewster Ready Care. That is where we have more, it's a little bit more systematic, and we're able to, use PPE in just a more efficient way if they all go over to Brewster Care. But again, like Dr. Senkirkle said, we do have PPE and appropriate resources at the other clinics if patients do present there as well. So trying to, take care of getting people to the right place. But if they do present to the other clinics, we can care for them. And we're also partnering with another company called Premier to be able to have more urgent cares in the community. And I believe that that should happen, I think, in November. I don't have the details on that. And then looking at Mission Woods to be our respiratory clinic beginning November 1st. So that truly would be a respiratory clinic.
I think that's very helpful when we have these respiratory clinics where we can really guide these people to it. And I think it certainly is going to help when you're not having that spread, when you're not having the non-respiratory urgent care visits mixing with the urgent care visits. And I know in our office, we were able to have an upstairs, downstairs. So it was strictly respiratory that came through. There was no mixing whatsoever. And that's helpful.
Okay, well, thank you. Very rich discussion. It's time for a very quick stretch break, as we called it. We invite you to stay connected. Please do not disconnect and come back. We will resume promptly in exactly 5 minutes. Are we closing up to 5 minutes? I must admit, I didn't check my timer, so I'm not sure.
Why don't we give them 1 more minute?
Okay. Okay, I think we had our 5-minute break. So let's get started again and move on from different types of outpatient activities, from testing, the community level, to urgent care, outpatient. Now we start moving closer and closer to what happens within a hospital. And the first panel will be about emergency room. Dennis?
Yes, thank you. Our emergency room panel is going to consist of Dr. Salah Najim from Stormont Vale Health, Dr. Kenan Thompson from the University of Kansas Health System St. Francis campus, and Dr. Alex Halleck, who's from the Veterans Administration Eastern Kansas Healthcare System. So, Dr. Najim, why don't we start with you? I think what we would be asking are the questions or the topics that I kind of would like us to focus on are, number one, how's your emergency department set up for COVID patients? What patients should be going through your emergency department, especially as far as respiratory patients? What are your plans for this winter when it usually gets busier? And how are you going to address if you start having staffing issues because of staff that are in quarantine, et cetera?
Good. So hi, everyone. So I'll start talking a bit. And as you mentioned, everything is connected, the outpatient, ER, inpatient world. And, what we've been seeing briefly in our hospital is, despite our ER volumes in general being down a bit, we're seeing sicker patients, and a lot of sick patients are coming through the emergency department and being admitted to the hospital. And our inpatient volumes have been on the higher side, and we've been quite full on the inpatient. And when this happens, it backs up into our emergency department. And you had this discussion about our urgent cares. Urgent cares have been doing a great job, awesome job helping out with the call before you go. And so this is one of the first gateways to getting to the ER is first calling the primary care, and then maybe calling the respiratory clinic, and then the urgent cares, and then eventually getting into our ER. In the ER, we set screening at the front door, and so we screen patients, and then it's set up in a way that if somebody's suspected to have COVID, they're quickly isolated into a special room, gowns, gloves, masks on all patients. And we have in-house rapid testing. So if the ER physician suspects COVID, all the tests that are done for COVID in the emergency department are the rapid test, the 1 hour turnaround. I know a lot of hospitals, and so we have different testing protocols. We have the rapid 1 hour test. There's a rapid 3 hour test. And there are the send out tests that sometimes take 24 up to 72 hours to get back. So we reserve the 1 hour quick turnaround testing for our emergency department. And that helps quite a bit with our throughput and for the ER for quick decision making if they're positive or negative. Labor, as I said, has been quite an issue, mostly on the inpatient world. We've been seeing busier inpatient, higher loads. This is backing up into our emergency department. So we've been boarding quite a bit of patients in our emergency department sometimes. So patients are staying in the emergency departments hours and sometimes days. So we do have a labor pool that helps out with the nurse staff. ICU nurses or floor nurses to help out, especially in the patients that are boarding in the ER. And we do have a surge capacity management plan in place. It's quite extensive, like a 3-page document, and I can share it with you later. Mostly, we started off with the ICU surge management, bed capacity, number of COVID patients, how do we manage the patients, how do you manage nursing staff? And then from the ICU, we expanded into the medical floor, and then from there also to the ER, how to manage if we get a surge. And the ER surge plan was partially from a catastrophe plan that they already had in place, and then changed it and fixed it a bit to adapt to a COVID, if we have a huge COVID outbreak or if there's a high number, how to manage them. And a lot of the surge capacity management depends on not only on the physical beds, so that's one thing that we look at if we have the physical beds, but also on the nursing staff, if we have enough nursing staff, and then we look at respiratory therapists, if we have enough respiratory therapists, and then we also look at, do we have enough equipment? And equipment could be anywhere from ventilators down to like, do we have enough endotracheal tubes, enough intubation kits to intubate? And so we kind of review everything and we kind of categorize each category and we rank it, or we put it in a, like we're in the green, yellow, orange, or red category for each. And when do we activate a orange or red category? And once we're in the red for a period of time, what are next steps? So this is a quick overview of what's going on in the emergency department for Stormont Vail. I don't know if there's specific questions.
Thanks. We'll and there may be, we can always come back if there are some questions. Dr. Thompson, let's go to you next.
Well, it looks like I'm here. It does not
We can
appear
hear
to.
you.
Yeah, you can hear me. For whatever reason. Oh, there it is. Now it says I cannot start my video because the host has stopped it. Oh, now it's allowing me to start. My apologies. All right, let's try it. Okay, let's try it again. All right, now we're there. All right, apologies. Thanks for allowing me to join you. Yes, at St. Francis Emergency Department, we are triaging all the patients who arrive at the door as they arrive. We have certain rooms in the emergency department which are preferentially designated to being for respiratory patients. We will try and immediately triage them back into those rooms, place them in isolation as prompt as possible. Of course, any room in the emergency department can be a respiratory isolation room if necessary, but we do have certain areas that we have preferentially designated for such. All personnel are appropriately gowning and donning gear as necessary as per protocols going into and out of the rooms. As was mentioned by my colleague there at Stormont, it does create a little bit of a flow issue because it certainly does restrict the number of personnel who can participate in patient care at any given point in time, because we do have to limit patient contact flow in and out of the room. We also have surge plans in place such that as we perceive that the number of patients with respiratory complaints begins to increase, we have designated accessory space down ground floor at the entrance to the emergency department, where we are going to open up as needed a separate waiting area where respiratory patients will be preferentially diverted to and supervised pending their moving back into the designated treatment areas back in the main emergency department. That particular secondary waiting area can be opened in just a few moments with the plan that we worked out when this crisis first hit back in March. Plans created by our administration were worked out. We actually, in fact, did create the unit for a while just to demonstrate how it would function, set it up. So we do have that in place. We have other surge plans as necessary, depending on the flow of patients that come into the emergency department, either by ambulance or by walk-in basis. We do also offer the rapid in-house testing, the antigen testing, which, as I understand it, the runtime on the machine itself is 15 minutes, but arguably the turnaround time is probably an hour, given the collection time, the return time from the laboratory itself. So we're very capable of running those tests very, very quickly. In fact, that is our preferred testing modality at this point in time. We offer the more extended respiratory testing panels as necessary, but our preferred testing is the rapid antigen testing, which can be performed on essentially any patient at any point in time. We also will do further testing on patients as necessary based on admissions, but there's no harm in testing a patient and allowing them to be dismissed home once they've already had that result available to them. Actually, I can't really think of anything much more to say on that, except to say, we do have surge plans in place. We work extremely closely with our house supervisors and administration regarding bed status in the hospital. We have extensive support from respiratory, from nursing staff, who, quite frankly, do an outstanding job of making their services available to us, such that when we in the emergency department notify them that we have a patient with any admitting diagnosis, but in particular respiratory diagnoses, they are very prompt and very efficient about making accommodations for those patients wherever the need may be in the hospital. Not speaking fully on behalf of the hospital, because I would leave that to Dr. Hyland, but they have made great strides in designating certain portions of the hospital to be specifically COVID-only units if necessary. Patients who are admitted with other diagnoses but have COVID as a co-infective possibility are also appropriately managed and sequestered as possible. Nursing staff, nursing personnel, respiratory personnel are all made aware of that. So quite frankly, we are prepared for surges as we can be. We have plans in place. We hope not to employ them, of course, as everybody would wish to say, but the emergency department will stand ready to do what's necessary.
Okay, thank you, Dr. Thompson. Let's go now to Dr. Halleck. Thank you, Dr. Halleck, for being with us. What about your emergency room?
Good morning from Eastern Kansas. Can everybody hear me okay? As far as the emergency department setup, given that we're right smack dab in the middle of renovating the emergency department, the current section that we have is a little bit limited on beds, which again, presents a little bit of a logistical issue, but we do have a hallway right off of our emergency department that is currently being used as offices, but we have already practiced converting it immediately into a COVID screening hallway if necessary. So we have an additional 4 rooms that could be used. It has its own a separate entrance and then exit, so we can actually screen the patients either at the front gate or at one of the 3 entrances that we have to our building complex. We have pretty much shut off all the other entrances, and you're required to go through one of the 3. So we have the ability to screen a patient, get them in through one of those doors, and then get them into that hallway to screen them. If the one room that we have specifically set aside in the main emergency department becomes sort of overloaded at any given time. We are screening everybody again for a 3rd time as they reach the emergency department. So you're going to get screened 3 times, either at the front gate through one of the main entrances, and then we have a separate person whose entire job is to screen you again when you hit the emergency department waiting room. So, and then you can get immediately shunted off to one of the rooms. As far as plans for the winter, again, surge capacity and things of that sort, we do have, each of our 3 entrances has a spot off to the side where we can isolate patients if necessary. One's in our mental health building, obviously one in the main hospital, and then one through our sort of our recreational hall where our canteen food service is located. We have separate rooms right off that entrance that we can isolate patients and then transport them over to the emergency department if, as necessary. We are fortunate in that we have a lot of conference rooms to utilize if necessary, so we can house patients in other places if we need to, and we have tested that capacity already. As far as staffing issues are concerned, we do have a number of staff that can come over from our sister campus in Leavenworth. The fortunate thing about Eastern Kansas is we have 2 full-service hospitals, and we can transport staff back and forth if necessary. Sort of to blend into the inpatient side, we have taken a lot of our primary care providers who have done some emergency department work in the past or inpatient work and sort of brought them up to speed on patients. So while they're not hospitalists or emergency department providers, they can certainly take over those less complicated, less sick patients if necessary. And then if the circumstances in Topeka become such that we need to ask for help, the VA has a disaster emergency personnel system where we can draw from personnel around the country if we need to. Since the pandemic has started, we have evaluated and sent staff to New York City, San Antonio, to other VAs. We do it routinely for hurricanes. We sort of have resources in place beforehand. So one of the good things about being a 168 campus medical system is we have that ability to ramp up if necessary to augment our staffing. Nursing, same way. Respiratory therapy, the same way. They have people on callback if necessary. And again, we can trade between the 2 campuses if one campus becomes a little bit more overloaded. Now, the emergency department in Leavenworth has been completely renovated, and it is open, and it has a number of beds too. So we do have, again, the ability to move between the 2. We do like the patients to call their primary care team or nurse triage first before they come into the emergency department. Obviously, after hours, they can go through the administrative officer on day and talk to one of the nursing staff or emergency department providers in the back and kind of get an idea if we feel like they are quote unquote sick enough to have to come to the emergency department to be evaluated. Obviously, if you're, we don't want you to come in if you don't need to, but obviously if you need to, or you're just concerned, please come on in. We do have rapid testing on site at both of our campuses. I think we're using the Cepheid testing now. We're getting ready to upgrade to the BioFire at both campuses in a couple of weeks. So we do have rapid testing available. And again, like the other 2 campuses, it's 1 hour turnaround. So we do have the test. And then obviously we have rapid flu testing and on-site respiratory viral panel testing. So we can pretty much do soup to nuts if necessary to get an idea about what somebody's potential respiratory pathogen could be. And then again, out of OR airway management, things of that sort, we have all the equipment, and we make sure that our staff is routinely taken to the simulation lab. Myself or anesthesia will run them through airway management. All of our respiratory therapists are airway certified. So as far as airway management, ventilator management, we also have tele-ICU capabilities out of Cleveland and Minneapolis. So we do have backup if necessary to stabilize and maintain a patient if necessary. Another thing that I don't think a lot of people are aware is, the 4th mission of the VA is to assist in emergency preparedness nationwide. So during this pandemic, if it's necessary to take an overflow from the community at either of the hospitals in Topeka or again in Leavenworth with the facilities around there, we have the capability and we are required to assist with that if necessary. So there is some potential overflow capability during this pandemic if necessary.
Very good. Thank you. Maybe we can have time for one question. And here's my question is, what are your main concerns from each one of you as far as with the winter coming on? What's that one thing that you're worried about? What's the one big concern you got?
From the VA, I'd probably say staff going down, and not necessarily can we get somebody there in a couple of days, but what do we do if we have a staff call in and they are positive and then we lose 2 nurses? The biggest issue with us appears to be just, can we maintain staffing sort of in the urgent? We need somebody within, 2 to 8 hours. I mean, we can do it. And again, we shift staff around, but that seems to be one of the biggest things. As far as surge capacity is concerned, as long as they're not requiring the ventilator, we have the ability to upgrade our rooms and various places throughout the hospital to take care of those additional patients if necessary. Plus the ability to house staff in-house if we need to too. We've done that for blizzards and things like that, sort of pre-prepared incident command and had people in-house. But I'd say our biggest issue would probably be staffing sort of in the emergent need.
Okay. Dr. Thompson?
Yes, I would agree. I believe that's actually the primary issue that we would have as well, is that at any given point in time, provider staffing can become an issue. If providers become ill, nursing staff, respiratory staff in particular, we will have some concerns there because the needs of the community are simply not going to start and stop on a dime either. So the ability to try and actually keep adequate nursing staff and others is going to be important. Now, fortunately, I think nursing and medical personnel in general do an outstanding job of trying to protect themselves so that they can actually continue to do the job that they're doing. But on our job, as in no other, certainly there are no guarantees. I would say, we're equally concerned about those personnel who are actually out on the streets, referring to the first responder personnel who are actually trying to actually attend to the patients directly in the community, bringing them into our facilities. I would say we have some concern there as well. The true frontline personnel and making sure that they are adequately protected with appropriate PPE, that they have the resources necessary for them to be able to continue to do the job that they are required to do in order to actually come and attend to the patients out in the public and even transport them to our facilities.
Sure. Dr. Najim?
Yeah, I agree with my colleagues too. So the three main things that I would worry about during the winter is staffing, as everyone mentioned, safety of all the providers and nurses, making sure we have the equipment. And the third thing, we talked about it up in administration, we talk about it every day, the morale of everyone. My concern is, other than, if we get a surge and winter with early nighttime, the days are shorter, the nights are longer. And if we're in a crisis, it kind of brings down the morale of everyone, all the staff, the nursing, the physicians. And so that's a big, big concern with a lot of, what we went through the past several months with a lot of policy changes and furloughing or at-risk jobs at risk. This put a lot of people down quite a bit. And and that's one of the concerns, might come back in the winter. And if it's worse, it's a big topic and a big concern for us.
Okay. Thank you all, both. Let's move to our next panel, which is on inpatient services. Our panelists for this would be Dr. Rena Letkamiller from the University of Kansas Health System St. Francis campus, Dr. Sala again from Stormont Vale, and Dr. Halleck again from the VA. So let's start with Dr. Letkamiller first. I think what we would be looking at here are the kind of the areas that we would like to talk about would be what changes you've made with your for managing COVID patients, inpatients. We've talked a little about surge planning with the ERs. What are the inpatient services surge planning? And how do you prefer to get referrals? In other words, we talked a little bit about this. It's easy maybe from your ER and maybe from some of the respiratory clinics, but there are a lot of other providers in the community. How do you prefer for them if they feel they have a patient that needs to be admitted?
Great, thank you. So first of all, thank you for having me on. I appreciate that. We do have definitely made a lot of changes to our facility, much like what you've heard from the various providers from the ED, where we streamline patients in through either front entrance and they're screened, or they go through the ED and they're screened. But we also have an excellent transfer line, and they get screened through that as well. We've limited patients to one visitor, and COVID patients, unfortunately, if they're positive, they are not allowed visitors, just to prevent further transmission and to protect our staff. the hospital's done a great job at looking at how to protect our staff, and we have cohorted patients into what previously was our PCU. We have 8 beds there. They're negative pressure rooms. We also have the capacity for another 8 beds on our 8th floor with negative pressure rooms if we do surge. And that opens up our ICU to be available for patients in the winter if we need more ventilators for non-COVID patients as well, with flu or whatever else is going to hit us, who knows. They have upstaffed as well, and have hired new nurses. At one point, as you heard, nurses and staff had been furloughed early on in this process, and now we're upstaffing. And also we are putting patients in like I said, a cohort, but we are using full PPE on all patients that are positive in that cohort, including N95, surgical masks, gowns, double gloves, and face shields. But the ER is basically treating all patients once they're in as if they have COVID until otherwise known, and they're doing a great job of protecting their staff by using N95s and full PPE on all patients initially, which I know is a great burden to them. We also have had increase in staff as far as physicians. We have a limited number of pulmonologists. They're all excellent, but at night we need help with if we are having a surge with COVID patients or flu patients or the both. And we have 2 hospitalists that have stated that they would help at night, as well as now the hospital is contracted with KU Kansas City to be able to do telemedicine at night. We have the robot, and we just went through training on that, and that's starting on 10/19 from 5 p.m. to 7 a.m. We also are, for non-COVID patients and flu patients and surgical patients, any other needs we have, we're reopening up our 5th floor, and as I said, had hired nurses for that. As far as protocols for the surge, we have gone through a fluid amount of protocols. I think probably every hospital has, but they meet daily to look at staffing. This is administration and staff to discuss PPE. I can look at any given time at a dashboard and determine where we have needs as far as staff or PPE or how many positives we have. So we have a dashboard daily. And let's see, what else was I going to say? Oh, and now we have done, opened up all elective surgeries and procedures, and doing so, they have increased capacity in our pre and post op areas and testing all patients prior to elective or procedures or surgeries in order to prevent patients who have needs from having to wait long periods of time and actually become more ill. As far as how do we get referrals, we typically have a good portion of our patients come through the emergency room. However, we have a transfer line, which now is coordinated with KU Kansas City. We are able to obtain patients from critical care hospitals in the surrounding communities, and in doing so, they're screened at that time as to whether or not there's a possibility of COVID, and a lot of times they're tested before they're even transferred to us. We then are able to determine what level of care they need and can cohort patients that are possibly PUIs or are COVID positive so that we do not increase risk of staff. As well as we are taking some of the transfers for KU Kansas City to enable them. Basically, they were getting patients from various critical access areas, and those patients were having to go clear to Kansas City. And with our relationship with them in the past few months, we actually are taking appropriate patients in order to help them. And then lastly, I would say that our ED is set up basically like Dr. Thompson had said. They're screened as they come in, masked, and all patients are treated as if they are COVID positive initially, which is a great burden to them and time management and such, but I think the staff has come together really well. I want to say that the hospital medicine program and our ED program are aligned. We're both with the same company, so we meet often and work together to identify areas that are potential problems for all patients, not just COVID. I hope I answered all those questions.
Yeah, very good. Thank you. Dr. Najim.
Yeah, so kind of what I talked about before earlier too. We do have a surge capacity management. We started our planning with the ICUs and then expanded to the inpatient and then the ER. So our ICU capacity, we can easily go up to above 75 ICU beds. So we usually operate somewhere between 40 and 50 ICU and intermediate care unit beds. And back in March, we redesigned a full medical floor to be able to convert it to ICU bed ready if we needed. And then we cohort patients in the hospital. So we have over 30 plus beds. Mainly these units are for medical COVID positive patients. This is separate than the ICU. We've been operating at above 20, sometimes up to the 30 positive COVID patients in the hospital. So we cohort them all in a separate unit. And then we have a separate ICU, separate from all our ICUs, that we just put sick COVID patients in it for the ICU. We try to cohort them away from our medical patients and from our surgery or post-operative patients, the cardiac, the neurosurgical patients. So we're kind of operating, I would say, kind of two hospitals at the same time. One mainly for the COVID positive inpatient medical and ICU, and then the general medical and general ICU and post-surgical. And you know, as they mentioned, also we do meet almost daily, and then all administration we meet twice a week and discuss all these patients, the planning, the policy changes, and if there's any major updates. What else? So we also planned for, and as I mentioned before, like if we need any supplies, so we can go up to 90 plus ventilators if we need to. We worked closely with what respiratory therapists and what we have as medical ventilators, what we have as non-invasive ventilators, to use them as ventilators, and with anesthesia to use their ventilators if we need to. Thankfully, we haven't been that at high capacity, but at times we've been pretty close. And the last thing I want to talk about is we do have treatment protocols for our COVID patients that we work very closely with our pharmacists. The data is changing every day. There was a big study that came out a couple of days ago saying that maybe remdesivir is not as effective as we think it is. So we work very closely with our pharmacist, reviewing all the data and the FDA recommendations and NIH recommendations, and update our treatment protocols for inpatient COVID positive patients and ICU patients, how we manage them.
Okay, thank you. Dr. Halleck.
I think when we talk about the Topeka campus, we sort of have to include the Leavenworth campus in it sort of as a combo, because when we think about each other, we think about each other sort of as a global whole. In terms of medical management on the inpatient side, the Leavenworth campus is probably a little bit higher capacity for sicker patients, given the staff that are over there. And I'm an ED doc and a hospitalist on both campuses, so I can directly speak to this. But we also have medical residents from KU that rotate through our Leavenworth campus. So again, you have more teaching attendings over on the Leavenworth campus than you do on the Topeka campus. Again, there's tele-ICU capability at both campuses. We can ramp up to 8 ICU/intermediate care beds in Topeka, 6 over in Leavenworth. But again, the 6 in Leavenworth can do more than the 8 can in Topeka, generally speaking. We also have the ability to, we've tested opening up our PACU as an additional ICU unit, which could probably give us another 4 to 6 ICU monitored beds if necessary. And we've also worked on rotating staff up there, not just physicians, but RT, nursing staff, EMS, to make sure that if we were to have to go to that kind of a capacity, we actually had the staff to be able to manage that particular unit. Our inpatient floor in Leavenworth has now been completely renovated and opened up. So we did get one renovation project completed. We can go to 24 beds on A2 if necessary. Over in Topeka, we still have our 16 beds on one side of the 4th floor, and the other side of the 4th floor, we have already practiced clearing them out from being offices and converting them back into inpatient rooms if necessary. So we could probably surge up to an additional 16 if it actually came to that. The plan is to, if we need to, move some of the sicker patients, quote unquote, over to the Leavenworth campus and keep some of the less sick patients on our Topeka campus. We do have the ability, and again, we've tested this, to isolate separate wards on their own HVAC system. So we can, for example, turn an ICU into our COVID unit if we need to. We've never had more than 3 to 4 COVID positive patients at any given time on either campus. Again, maybe it's just our patient population or what has it, but we do an incredible job of screening the patients so that we can get them to the appropriate place. We have a 160-bed domiciliary unit over on our Leavenworth campus, and those patients get screened on medicine in isolation before they go over. Our community living centers, which are our nursing home care units, and we have one in Leavenworth, 3 in Topeka. If I go over there to do a procedure with them, I pretty much have to have not been seeing a patient for 24 hours before I'm even allowed to go over there. And then I'm required to put on a fresh set of scrubs and things. So we're limiting access to our other units. We're with multiple steps that you're having to go through to get there. So surge capacity. And again, we also have the Kansas City VA for higher level care. We do use KU Medical Center. God bless St. Francis and Stormont Vale. We use them quite frequently if we need to, and that relationship there we are tremendously appreciative of. As far as referrals coming into the campus, either campus for that matter, and I would say that the Topeka hospitals should not have any qualms about calling our Leavenworth campus either. If they just need to move out less sicker patients, they need to make room for a patient, they have a veteran over there that wants to come to us. The best thing to do is probably to go through the administrative officer of the day in the emergency department, because they will be able to get you in contact with either the emergency department physician or the hospitalist, and then the hospitalist could take the call directly to see if the patient is a candidate for coming over to one of our 2 campuses. We do have a nurse triage during the day that can be utilized also, but that's usually utilized for patients and not staff from other hospitals. In the past, I've worked for Eastern Kansas for 20 years. I am also a contact. Again, I've been ER director, I've been chief hospitalist, I've been chief of staff, and now I'm overall trainee education in both graduate medical and allied health. So if you can't get the answer from someone, I can certainly help you find the person that you need. I know we never like to have response systems reliant upon one person, because what do you do if that person gets COVID? But there is the possibility of that also. We do have a daily bed huddle between the 2 campuses, so we are able to get an idea of what subspecialty care is available, what the bed status is on either campus pretty much at any given time. To echo Dr. Salah, we also have pharmacy that's intimately involved in any kind of antimicrobial therapy, be it antibiotics, be it the remdesivir, being the ability to get a hold of dexamethasone, whatever treatments appear to be in vogue this particular week. We do have the ability to get a hold of them if necessary. And as I mentioned before, we have staff from our primary care teams that we have put through sort of a reorientation on the inpatient service to be able to augment if necessary, if they have to go upstairs to assist with just simply the sheer number of patients we have, they can do that. And then we can have the sicker patients be treated by the hospitalist. And then again, tele-ICU capabilities, they have the ability to log into our system, our computerized medical record system, and put in orders, run code blues. So they are right there if necessary to assist with patients. They can manage the ventilator, they can do whatever they need to. The cameras are so good, they can evaluate pupil response inside each of the rooms. And we also have those set up in the 2 trauma rooms over on the Leavenworth campus. They've been completely redone. Let's see if there's anything else here that we have. We talked some of the stuff that we talked about in the emergency department. Morale, I want to echo that from the past. That's obviously been a big, huge issue, not just with the other campuses, but with our campus itself. And again, I can't say that we've done some magical ways of handling it, but it is something that I want to echo in the past that we have tried to work on. Fortunately, our hospitalists do a 7-on-7 off rotation, and so they do have that ability to take some time off if necessary to try and recharge their batteries, as it were. And then again, just ramping up to other VAs. We have an allocation team that has been put in place to make sure that we are consistently up to date on the kinds of equipment that we're actually going to need. We can probably manage 4 ventilator patients on each campus. And then there's the non-invasive ventilation, which we have pulled out a number of times. As far as PPE is concerned, I know there's the question there from nursing and the other staff that needs to go in there. We do have the capability of fit testing someone, maybe not after hours, but during regular business hours we can. But we also have a number of staff, including me, that can respiratory clear a patient to use the PAPRs. We have a number of PAPRs throughout the facility. We probably everybody in each of the units has their own PAPR that is pretty much hoods pretty much changed on a routine basis. And I think for the purposes of what we've been doing, we've pretty much been using PAPRs instead of N95 masks when we go in and we evaluate patients. And we have, again, our supply system has been able to keep us in stock as we need to. N95 masks are available for those patients and those staff that want to use them, but we've pretty much gone to a full PAPR system. None of our trainees throughout any of the disciplines are allowed to see COVID positive confirmed patients. So we do have them safe on the side too, because they're sort of that loose end that nobody ever kind of thinks about. Trying to think, I think that's and again, we have increased the number of negative pressure rooms on both of our campuses, specifically because we're able to isolate particular wards. Again, we can turn our PACU, we can turn either one of our ICUs into an ICU fully monitored unit if necessary, sort of at the drop of a hat. And fortunately, we've practiced this with sample patients, with sample staff and things like that. So we know that it'll work in a pinch.
Okay, thanks everybody. We're in interest of time. If you have any questions, put them in the chat box and I'll ask the panelists to maybe get back and answer those. We're going to take a
Danny.
break.
So let's move on. We're running a few minutes late. Yeah. We are moving now to a presentation, which will be a little different from a panel. And Alison Alejos from the Kansas Department of Health and Environment will talk to us about vaccination plans. And then we'll go back to 2 more panels, one on schools and the other on mental health before we wrap up the day. Alison?
Hi, I'm glad to be here today. Can everyone hear? Can you hear me?
Yes, we can hear you well.
Okay, perfect. Okay, so I'm here today. I work at the Kansas Department of Health and Environment, and I am in the Kansas Immunization Program. I was asked to talk a little bit about the COVID vaccine and administration. So I've got some information, and I feel like I need to state that just like you all are very aware of, this information is subject to change and very likely will. So just keep that in mind as I go through some of the high-level information that I have. So we know that in order for us really to get society up and running and back to normal, and to keep people from getting ill, prevent hospitalizations, and really to prevent those deaths that we're seeing, we have got to have a COVID vaccine that is in our arsenal to use. It needs to be safe and effective, and it needs to be available as soon as possible. So we know that Operation Warp Speed is working very, very hard to get vaccines developed in a safe and effective manner, and so that they're available for distribution. Probably we here in the state of Kansas are planning on early to mid-November is kind of what our time frame is. However, I think all of us know that may not play out that way. So we will stand ready when that work is in front of us. So in the meantime, we know that the plan from Operation Warp Speed is that they want to have 300 million doses available for use across all the entire population of the U.S. And likewise in Kansas, we want to make sure that we've got vaccine available for those Kansans that need to receive it. So our goal is to vaccinate every Kansan with a safe and effective vaccine. We do know that because there's so many questions and so many unknowns right now, that we have to be really flexible in the way that we plan and prepare for vaccine distribution and administration. There are currently 151 COVID vaccine candidates that are in development. 10 of those are in phase 3 trials, clinical trials, and they are being conducted at the exact same time that large-scale manufacturing is occurring. So the way the general who is overseeing Operation Warp Speed has described it to us is that the risk that the government is taking has to do with the fact that they're manufacturing vaccine that is in the phase 3 clinical trials before approvals of any type are being made. If it is determined that the vaccines that they have manufactured are not deemed safe or effective, those vaccines will be discarded. They will not be used. They will not be distributed for anyone. And that's really is the financial risk that they're taking, but they're currently manufacturing vaccines at the same time they're going through those phase 3 clinical trials. So that is really the risk that they want us to understand. And they also are reiterating that they're not that they're working hard to make sure they're following all the safety criteria when they're looking at and developing those vaccines. So as far as what we're doing here in Kansas, I said that we're planning on looking to have some doses available possibly in November, and that supply is going to rapidly increase as we go into 2021. Again, we don't have definitive dates for availability of the vaccine, but we do know that we should see something hopefully soon. We do not know at this point if the vaccines that are being evaluated are going to be licensed or approved through an emergency use authorization. The FDA will make that decision with the advisory committee immunization practices, advisory committee on immunization practices, and that scientific review that is going to go on as those vaccine candidates come forward. State and local partners are working really hard to make sure that we have the correct match of the COVID-19 vaccine product, and we understand the dosing intervals. And I think probably most everyone has heard that that the vaccines are expected to be 2-dose series. There may be one candidate that's looking like only one dose is necessary, but most of them are going to be a 2-dose series that are separated by 21 to 28 days. And a factor that complicates the issue is that those products are not going to be interchangeable. So if you start with your series with vaccine A, you must complete it with vaccine A. You can't use vaccine B, C, or D, whatever the case may be. And so that's going to pose a challenge for us as we try to plan and ensure we've got the correct amount of vaccine allocations in the correct locations for the correct population to make sure that they are in fact able to get the safety and effectiveness of the vaccine that we want to see. We do know there's also going to be some challenges as it relates to the cold chain storage and handling. We know there's going to be some refrigerated vaccines, so that's going to have to be kept between 2 to 8 degrees Celsius. We'll have the frozen vaccine, which is -15 degrees to -25 degrees Celsius. And those of us that have dealt with vaccines in the past understand those requirements, and most of us are set up to deal with those. But there's now ultra cold storage, which is the -60 degrees to -80 degrees Celsius, which is something that not too many of us are familiar with, nor have the storage capacity to maintain those vaccines at that particular temperature. So those are some of the complicating factors or considerations that we all have to kind of keep in the back of our mind as we're moving forward in vaccine planning. We have been told very plainly that states are not expected to purchase ultra cold storage units. So if that is something that your organization or facility is planning on doing just for the sake of COVID, please reach out and talk to us at the Kansas Immunization Program. We'll give you some more information on that. The final consideration for the vaccine is that the products that we have, some of those are liable to have a requirement for reconstitution, whether that's through a diluent or if it's through mixing some sort of adjuvant in it before it's actually administered into the patient. So there's these vaccine types that we're talking about do have certainly some new considerations for us as we're moving forward, and things that we'll have to be prepared for in terms of teaching staff and the public about what they're looking at and what we're doing and why. So we should, when we start to see the vaccine allocation roll out, again, we plan to see limited allocations coming out through the state. How those allocations are going to be determined by the federal level, it's very unclear to us at this point. We do know that our plans that we have been working on are really, we identify 3 phases of vaccine distribution, and phase 1 is really geared towards those high-risk healthcare workers. And when I say healthcare workers, I'm using that term very broadly to describe not just physicians and nursing staff, but also environmental health services, dietary, maintenance, any of those folks that might have access or be exposed to folks that have COVID-19 infection, and are that exposure, if they're in line for exposure, we want to make sure that they're counted in that initial population of critical healthcare workers that are likely to be exposed, but also looking at those that have health conditions that put them at increased risk for severe illness or disease. We want to put those in our initial allocations, and other essential critical infrastructure folks, fire, EMS, those folks that work very hard on getting patients to and from and are really at risk, as well as the physicians, nurses, and others in the hospital or clinical setting. So those are all things that we've thought about and are working on within our planning efforts at KDHE. We will continue to look for and see guidance as it comes down from the federal government to help us inform the decisions that we're making at the state level. We want to make sure that the vaccines are going to go out in an equitable manner. That's very important in the work that we're doing. And just as to kind of follow on that, at KDHE we do have 2 COVID-19 vaccine planning committees that are, one is currently in place and the other is soon to start. The first one is an internal planning committee, which consists of primarily a variety of program areas from the state of Kansas, to include the immunization program staff. We've got emergency preparedness, we've got communications, we've got representation from our ICS team, the incident command structure team, just a variety of folks. But we've also got folks from the Kansas Hospital Association, local health departments, and also from Community Care Network of Kansas, which is the state's primary care association and represents the safety net clinic. So those are all on the internal planning committee, and we are just really getting off the ground and doing some work right now in that arena. But there will also be an external higher level committee that is that consist of representation from several of the same groups I've listed, but also organizations or associations that are involved and interact with populations that are deemed to be high risk, that may have some disparities that we want to make sure get accounted for and are in front of us as we're making decisions. So this group is really going to be talking about the equitable distribution of the vaccine, and they will be looking at the framework that was developed through the Johns Hopkins Public Health and through the National Academy of Science, Medicine, and Engineering. All those frameworks they've put together, and that is the work that this higher level group committee will focus on, is really trying to identify within Kansas who are those populations and how do we want to make sure that we're allocating the vaccine doses equitably across all populations in the state. So they've got some hard work cut out for them. We've got facilitators that we're getting ready to get on board, and they're going to help. So some of you may be seeing invitations coming out, and obviously if you have any ideas of folks that definitely need to be considered and at the table, reach out to me. I'm happy to take those names or contact information and put those into the discussions. Some things that might be of interest when we talk about the vaccine allocations, when we start to receive those in the state, we expect that there's probably going to be a minimum number of doses that need to be ordered. So the minimum order that they expect is probably going to be 100 doses. So we have storage, not only in terms of temperature regulation, but also size. And of course, we're in the middle of flu season, so we know vaccine refrigerators are really full with vaccine in addition to other vaccines. We've got just lots of things happening in the clinical setting, and to add the COVID vaccine to the mix is going to could be challenging for some clinics and hospitals. But they will come in minimum orders, such as that. The vaccine orders, when they're placed, they will also be coming with what they call an ancillary package. And within that package, you will see things such as face shields and masks. They will have needles and syringes. Alcohol wipes will also be in there. They will not have sharps containers, Band-Aids, or gloves. Those things will need to be purchased by providers, and we at the state are actually looking for a solution so that we can provide those additional needed supplies out as the vaccine goes. And then there's also going to be mixing kits that will come as well, and that will have the components that are necessary to use in the vaccine to get it mixed and prepared for administration if that's a requirement. So all of those things will come out and be delivered through existing infrastructure. We have our centralized distributor that CDC has contracted with. They'll continue to do the work of distributing vaccine. There are some nuances in there, and I'm not going to try to get into that level of detail, but we will see the channels in which vaccine is received is going to be very similar to the way it is now if you're a vaccine for children provider or a VFC provider. And do know that at the state, we are trying to keep those processes as similar as possible to avoid confusion, to try to minimize the need for additional training that, there's so many things going on. Just to have one less thing to have to worry about is really what we're trying to accomplish in spite of all that's going on. We do know that when the vaccines are shipped, the shipment of the ancillary or mixing supplies will come probably in different shipments, but they'll come. You'll get the ancillary supplies and mixing stuff probably before you receive the vaccine, but they'll all be there in time for you when the vaccine is arriving in your facilities. So we, as far as something that hasn't been, it's been talked about a lot, but there hasn't been a lot of information that has been provided, has to do with the provider enrollment. So how are people going to be able to sign up to be a COVID-19 vaccine provider? We are in a process of working those details out. There are required documents from CDC that must be filled out by each facility that wants to be a COVID-19 vaccine provider. So you have a provider agreement along with a provider profile that has to be filled out for each facility. So just as an example, we'll use the KU Health Services, the health system. So if their organization completes the provider profile agreement, they have to be signed by the medical officer and the chief executive officer both must sign this document. And then they will fill out for each one of their clinics that they want to participate in providing the vaccine. They will have to do a provider profile for each one of those associated clinics, but they will tie back into that overall bigger agreement, which is something that will be distributed here soon. There's also a redistribution agreement. So for example, in the KU example, if they have multiple areas that they want vaccine, but they're going to house it at one location, they will go there. If they want to be able to physically move vaccine between facilities, they have to get a redistribution agreement completed, submitted to the Kansas Immunization Program. We will review it, and the review will be based on ability to maintain the storage and handling requirements for those vaccines, and it will only be allowed for refrigerated vaccines. So there is an approval process, and that will be handled on a case-by-case basis. But nonetheless, the provider enrollment agreement and the provider profile must be submitted. The way we're going to handle that at the state is we are trying to put together a fairly easy electronic submission form that can be handled and shared among other clinics within the organization to fill out the provider profile agreements and then submit them electronically back to the state. We will start with the hospitals because we anticipate the hospitals will most likely be the first providers of vaccine in the state. They'll have the highest, the critical infrastructure that we're really targeting, along with those that are really severely affected by COVID-19 or have the potential to be. And so we will target them. We will then expand outward to the local health departments and to the safety net clinics, and then out to providers in addition that want to participate in these activities. Again, it's kind of like dropping a pebble into the lake and watching the ripples flow out. Everything is just builds on the next and just continues to get bigger and bigger and bigger. So there are still a lot of unknowns and a lot of things we're trying to work out, but that is really kind of what we're seeing in terms of getting the information out there to others. And again, I think that's probably a pretty good place to start. I guess one final thing before I stop is that providers that have COVID vaccine, and we just heard this week, will be required to keep their vaccine inventory in Vaccine Finder. And some folks use this for flu clinics. They'll put their vaccine in there, and the public can go in and look for where vaccine's available. Even if you have only what we refer to as closed points of dispensing systems available, so you're just vaccinating for your internal staff, they still want all facilities that have any COVID-19 vaccine on hand to report their inventory in that system and keep it updated on a daily basis. So one of the key underlying themes of this vaccine administration distribution is transparency for the public, being able to report real-time data and let everybody understand where we're at so we can gauge our performance, make sure that we're getting vaccine to the correct populations and we're moving it. And so it's not just sitting there waiting to be used, but really it's being actively utilized in the communities and with the folks that need to have it. So with that, I'll stop. Thank you for the opportunity. I'm happy to answer any questions.
Thanks, Allison. I think why don't we go ahead and move to our discussion panel with schools. And if you have questions, just put them in the chat box and Allison can answer them there. So our next panel is going to be on schools, and we're going to have Dr. Tiffany Anderson, from the superintendent from USD 501, Mr. Tim Hallisey, who's the superintendent from USD 372, and Chris Tuck, who is our Shawnee County Health Department liaison to those to our schools. And maybe if our panelists could just briefly tell us a little bit about their mitigation efforts and what they see as major problems in the coming months. And Dr. Anderson, would you start us?
Sure. So for those that don't know, Topeka has a little bit over 13,000 students in Topeka Public Schools, and it has caused for us to use a variety of methods to truly reduce the spread. And thus far, we feel that we have been relatively successful in not seeing any outbreaks in most of our schools. And for those where we have seen community spread into the schools, it has been minimized and contained effectively with the great help of Chris Tuck and others who have just helped us respond pretty quickly. So the efforts that we are doing, and I'll speak broadly and then specifically by giving a couple of examples to kind of stay within this 5-minute time frame. One is that when we started, we did delay until after the September 9th timeframe to really give us time with that number of students to get in place the 3 different cleaning mechanisms that we use nightly, which includes the UV lighting, sprayers, foggers. All of these are used every night in every classroom. And so once we received all of those items, we truly felt that we were ready to not only address social distancing and masks and all of these other protocols and PPE equipment, but we really were prepared to address deep cleaning literally every night. So with that, we really have a schedule that allows us to launch something that we researched late into the summer, which was micro classrooms. We noticed that places that were having minimal spread and outbreaks, and even China at one point in New Zealand, they were using these micro classroom models where you have less than 15 students, sometimes 2. And for us, it's about 7 students in a classroom, elementary, middle, and high, as many as 15 in a classroom. And having that small, stable grouping, being able to attend class and proceed forward has not only minimized the spread of COVID, but just to minimize the spread of anything, actually. We are seeing just a variety of positive effects from that, instructionally, academically, social, emotionally, but everything from the common cold to anything else. We're able to contain it quickly, send students to an isolation room, have them picked up, and it's just noticed more quickly if a student has even a runny nose for that matter. So it just really has helped us. So we started that with elementary only. And then just before middle and high opened, we really had the conversation about, since we saw several weeks of very few illnesses, that perhaps this is something for middle and high if we could make it happen. That's a little bit more tricky because without purchasing space and renting spaces, we had some complicated issues to contend with. And the hope is that we can actually replicate things in ways that don't cost a lot of money so that it could be replicated in other districts. I mean, that's really the hope, not to just do something that we can do with grants, but have a system that's sustainable. Therefore, the middle and high school model really is a little different. Our students were at the time learning remotely and bringing them back. Initially, we had planned to bring them back for 2 days. And again, stable groups, small numbers, 15 or so to 1 in a class, and then those students would go home and we'd wait one day, deep clean, and the next day bring the other students back, which gives students 2 days of in-person learning. The problem with that from students meeting with me was the social emotional impact of students. I mean, ultimately, adolescents, they need to move out of this form of isolation and have regular contact with people and with counselors and social workers. The other piece for us, we're 73% poverty. So hot lunch and breakfast is critical to our kids. And so we made the move of having kind of a micro model at middle and high. Now, we were already testing it in our alternative schools, and there are 4 of those. Those were successful. They're open 5 days a week, like the elementary. So now the high schools, which would be Topeka High, Highland Park, and Topeka West, then opened with a approximately 7 a.m. It's about 7:30 a.m. Kids get out at 11:30. They come in small groups, class sizes, again, 15 is the highest. Generally, 7 to 10 is the norm in a high school. And that first group, Group A, goes to class. Social distancing has been excellent in our buildings, just the class sizes are so small when you don't see it. You know, when you see an issue, you can address it pretty quickly, but kids are so glad to be back at school. They wear their masks without reminder. The preschoolers, they have things hanging from the ceiling to let you know where the 6 feet are. Kids are being very, it's amazing what kids can rise to. So high schoolers are no different. They're complying, and our students leave at 11:30. They come have breakfast, they get a grab and go lunch, and they leave, and they leave relatively quickly because they know in order for this model to work, they must follow protocols. And then the B group comes at 11:30 through a different entrance. They have lunch first, they go to class, again, small groups, and then at the end of the day, they get their breakfast for tomorrow and they leave. Through this, thus far, it's been very effective for us. And I'll stop there. That's kind of a real general overview of what Topeka looks like. And I'll turn it over to my great colleague, Mr. Hallisey.
Good morning, everyone. Thank you, Tiffany. Yeah, a little context about Silver Lake, and we're in Northwest Shawnee County. We serve 700 to 750 students, and we are full on-campus learning every day in both our elementary and secondary, and have been from the start. We had approximately 3% of our students initially chose remote learning. Nearly all those reasons for those families were they had somebody within that household who had a compromised immune system. They were worried about that. It has gone remarkably well. We have almost all of those remote students are going to transition back to us next week. So again, we're going to have almost everybody on campus with that. We spent nearly 2 months this summer changing things to get ready for this year because we thought we were going to be able to do on-campus learning, given some of the advantages we have with scale and size. So we spent weeks reconfiguring classrooms, physically changing those. You know, over the last 10 years, our classrooms were beautiful examples of collaborative learning, work tables, common workspaces, application of knowledge and skills. Our classrooms now look like they did 20, 25 years ago, more isolation in general. So we'll be glad when we can get back to more normalized, better instruction setups for our classrooms. But we reconfigured classrooms, adjusted procedures. We spent a lot of time adjusting class sizes, reducing those so that we could get the true 6 feet distance between each student in class. Doing those. For those classes that we couldn't, we have classes in our commons, our PAC, library. We've emptied out rooms. We've moved classrooms that had relatively large spaces like our journalism classroom. That is now a flex classroom for classrooms that have 23, 24 students. We can space them out appropriately in there. So we've adjusted all of those. We adjusted our cleaning procedures and how we would disinfect each desk between, because our secondary 7 through 12, they follow a set schedule. They're on a bell schedule, 7 periods a day. They are moving every 53 minutes. And so we have to have cleaning procedures to allow us to do those kind of things. Arrival times, dismissal times, changes with transportation were all adjusted. Lunch procedures, how we would do that, how we eliminate common contact points. We have utilized a tremendous amount of outdoor space. And so we will continue to do that as long as weather allows us to do that. We have an outdoor classroom. We have another outdoor classroom in process now that we're having put in. So we've done all those kind of things. We nearly doubled our nursing capacity, and we changed our air filtration system to try and create a better flow through our HVAC. So we've done all of those kind of things. And again, it's just simply, we are infusing social distancing, hygiene, mask requirements, and space into our procedures. And we've literally changed hundreds of things to make that happen. As Dr. Pizzino alluded to earlier, it's been remarkably successful so far in keeping classrooms safe. We have had positive cases, and those are all coming from older siblings, parent workplace exposures, those kinds of things. We still do not have a in-class transfer that we can trace and make a case for. So we've been thrilled with how that's worked. We have made it through a quarter, so we are 25% of the way through the school year. If you would have asked me back in early August how far we would go, I would have told you that if we made it through September, that'd be a win. But we've been able to do that. And for the most part, we've been able to also do activities, although we do think that we will continue to have issues with activities, and that will be a point of spread as we move through the year, especially football, basketball, wrestling, those high contact types of sports there. So one of the things that has been extremely helpful, Shawnee County Health, as they have upped their capacity in game, we, I think, have a huge advantage of the other 104 counties in Kansas. We have access to medical advice, healthcare advice, all those kind of things that we constantly weave into our day-to-day operations and take advantage of that advice when we have to deal with an outbreak. And that has been extremely helpful in keeping us safe, limiting those outbreaks, and allowing us to continue to go to school. And so I do appreciate that and the work that they've done and the late contacts that we've made with Chris Tuck to keep us all safe. So it's gone very well, and I am grateful for that. I'll turn it over to Chris.
Well, I think you've both summed it up. My role has really been in working with the school nurses in the 6 public school districts that employ school nurses. We also work with the 11 private schools in Shawnee County, with only one of them employing a nurse who is an LPN. And we also are working with Washburn University. And my main role is just to communicate with those points of contacts, which are typically the school nurses or administrator in the private schools. And when we have referred a student or staff member out, I begin watching for their test results. The school is beginning to do their contact tracing, looking for those close contacts. So once we have a positive test result, we are ready to act. Dr. Anderson, and I know even Tim there in Silver Lake, we are actually finding out how valuable video surveillance has been in assisting us in contact tracing, whether that's on the school bus or actually timing the total time that students are with a teacher, if a teacher tests positive, et cetera. So it's been a real game changer for a lot of these superintendents. I have the utmost respect for them. School nurses have always been very active in disease surveillance in their schools and in that school community surveillance, but this has definitely upped everyone's game. We have not seen a lot of sick children. I know Dr. Cooley had that as a question, the protocol for sick children. We've had very few referrals, out of the school building because a student is running a fever or having specific COVID type symptoms. Is that because the schools have done such a great job communicating to parents and they are actually keeping the kids home when they're having COVID-like symptoms? I don't know. Is it because of the mitigation strategies we have in place that we truly are going to see fewer cases of strep throat and influenza as we move into influenza season? These are all hypotheses. It's going to be interesting to see how it all pans out. But the contact tracing has gone very well in the schools. The school nurse or a point of contact works with myself, and we can actually place a staff member in isolation and then quarantine those close contacts. I work with Dr. Cooley and Dr. Pizzino and Derek Flairlage on every positive case. Some of them are quick and easy to figure out. Some of them might take us half a day or a full day to completely figure out. But I think we make a great team and we work very well together, and it'll be interesting to see how the rest of the school year pans out.
Okay, thanks, Chris. And actually, thanks to all our panelists. Again, in the interest of time, we're a little behind. I'm going to go ahead and we'll move to our next panel. But if you have questions, please put them in the chat box so that our panelists can answer them. And I'll also want to mention that Allison has some information on vaccine side effects that she placed in the chat box that I would ask all of you to please check. So our last panel is on certainly a discussion of our mental health facilities, and our panelists include Brenda Mills from Family Service and Guidance and Dr. Laura Seidlinger, who's from Vallejo Behavioral Health Care. And certainly we would ask that you tell us what services your groups provide, how your hours are, and referrals. So Ms. Mills, why don't you start us out?
Forgot to take it off mute. Hello, everyone. Both Family Service and Vallejo Behavioral Health combine to provide the public mental health system in Shawnee County. So what that means is that we see folks regardless of their ability to pay. So we have Family Service and Guidance Center serves about 5,000 kids each year in active treatment and taking all forms of payment sources, including subsidized funding for the uninsured. Just to put context in, we provide outpatient services such as individual, group, and family medication management from our psychiatry team. We do a lot of community-based services, case management, attended care, psychosocial group, a lot of services in the schools. We have a mental health intervention team that works in conjunction with behavioral health liaisons at 501. And we also have staff that work in a variety of the other school districts in the community in partnership with the folks there. Probably one important thing that everybody needs to know is we do provide 24/7 crisis services. This is not for children who are actively presenting with suicidal ideation or whatnot. Those folks are screened into an inpatient facility, but we do have a crisis facility, and that is one place where we've had to scale back some in the pandemic. I'll talk a little bit more about that in a second. Just quickly, I mean, our office hours are 24/7. Call 232-5005 if anybody has someone that's experiencing a crisis. Our normal office hours are, I think, Monday through Thursday, like 8 to 6, and Friday 8 to 5. But there are some options for some of our community-based services are outside of those hours. So we're just really here to meet the needs of the community. In the beginning of the pandemic, we had to shift on a dime back in March to provide our services remotely. And so that meant virtual phone and video services primarily, which is a challenge to do when you're working with kids. They don't like to stay engaged for the length of time we typically would have seen them pre-pandemic, but we did a pretty good job, and we learned a lot of things during this that for families that had transportation issues and those sorts of things, this actually worked better for some of them, particularly for medication management appointments. So some of those sorts of things have continued, but as we've moved along here and are able to start seeing folks in person, it's valuable for us to have kids coming in to the clinic or for our community-based services folks to see them out in the community. Of course, like others, we're trying to do as much outside as possible. As the weather gets colder, we are starting to allow our staff to go into homes and into other settings, as long as everyone is masked up. You know, to come to services with us, everybody has to go through a typical screening, just like you would have if you go to the doctor's office. We take temperatures and do the whole screening process, and anyone that presents as ill, they're not turned away. They're asked to either go to a special room we have at the facility where we can go ahead and do a video appointment right there at the facility, or they can return home and do that as well. We are one thing that we did notice though during the summer is our initial admissions started dropping pretty rapidly. Anytime the kids are not interacting in the school system, we see our referrals dropping because so much coordination happens between the school system and us. And so I really am glad to see that the school districts are able to keep kids in the classrooms. I think the teachers having eyes on those kids is really, really critical to making sure that they get connected up with the public mental health system. One final comment that I know that our providers are really starting to see a lot of stressors from parents with these kind of hybrid schedules and flexibility, and that's kind of needed in order to get kids their education, and that kind of disruption in how they deal with their work schedules around their kids is really causing a lot of stressors for parents, and that's kind of manifesting itself in some pretty challenging mental health issues within the family unit. We're starting to see a big increase in anxiety, requests for anxiety treatment at our clinics. So tough time, but for us, the more that kids can be in school, the better. So that's all I have.
Thank you. Dr. Seidlinger.
Hello. I'm so pleased to be on this call today with you all. Just a really brief overview. Vallejo, we have 24/7 crisis services as well. They can be accessed at our 400 Oakley location. We also have a 24-hour crisis hotline, 234-3300. For anybody can call in and talk to a clinician, and then they can make a determination whether they should come on in to stay at our crisis residence. Typical length of stay is 3 to 5 days. It is staffed with crisis case managers and mental health technicians. It is not a hospital. If we do feel like at the intake they need a higher level of care, such as an inpatient hospitalization, we will coordinate that admission. We do have outpatient services available at our various buildings. Primarily, the things I think that have been most referred to lately has been our medication services and our therapy department. We have found telehealth to be hugely beneficial for our population. We actually have had better show rates in our medication services and our therapy appointments than we've ever had before. And I think because people are still receiving care, that they haven't decompensated nearly as much as we had anticipated. I sit on the chair of the medical directors group for all of the mental health centers for the state of Kansas. And only 2 mental health centers have actually seen an increase in service requests, down in Southeast Kansas and out in Western Kansas. All the other departments really have felt like things have been pretty stable. In fact, the demand has been reduced. And I think that's somewhat because the severely persistently mentally ill population actually does quite well on their own. And the isolation didn't impact them the way that it has a lot of other groups. So the other thing I wanted to mention is that we do have a substance abuse treatment program here. We did have to reduce the capacity of number of beds because everyone's in a single room, whereas typically we like to have people doubled up because that teamwork and that having someone else to talk to in recovery tends to be a better model for recovery. But we have noticed, as we all know, that there's increased substance use during the pandemic. So we are very grateful that we're able to continue to have that residential program open and to be able to offer detox services. Although again, we did have to decrease the number of detox beds because of the physical distancing that's required. Everyone is universally screened for flu-like symptoms when they come to Vallejo for any of the services, staff, consumers, and guests. We do the temperature screen for symptoms, travel, and everyone does wear a mask. There's a couple of exceptions due to medical conditions or related to trauma situations, but we do require them to wear face shields then. I wanted to echo what Chris said about contact tracing. We have actually used video surveillance for contact tracing for timing of contacts, and that has been very helpful as well. We have I really feel like things have gone well. We still do have our crisis co-responders out with the police department to try to help with the mental health crises. We have not hit capacity at our crisis residence yet this season since the pandemic has started, even though we've had to reduce the number of beds. But we do anticipate that we will need at some point to see more people coming in. I will tell you right now, with all of our provider services, we feel like we do have the capacity to flex up and to accept more consumers. Case management maybe is the tighter area where we have those services where they actually go with individuals in the community or to try to help more one-on-one. They are a little bit tighter with capacity. But as far as our prescribers and our therapy department, we are still able to see patients. And I'll be happy to take questions if you have them.
Thank you, both of you, for that presentation. Why don't I don't know if anybody has any questions here in the next minute or so. Again, you might.
I don't see any. So Dennis, probably we should start to wrap this up, and I will leave it up to you to formulate some closing concepts and ideas for how to move forward.
Sure. So first off, I want to thank all of our panelists for spending a very nice Saturday morning with us. And again, also want to thank all of those of you who are attending this meeting again. We hope that certainly that our objectives have been met, that we've been able to share some information, understand what's going on in the community with COVID-19, and also kind of start to maybe understand where some gaps are. Dr. Pizzino earlier had mentioned that we had an idea about whether or not it would be of interest to all of you to have a kind of a routine meeting with our providers, you all, and Shawnee County Health Department, maybe something on the order of a once a month meeting, 30 to 60 minutes. It could be on a Saturday, it could be whenever. And that's something that we would be interested certainly in coordinating if that is of interest to all of you. Now, I don't know, Derek, were we able to get a poll that we can use or not?
No, we passed on that idea, Derek.
Okay. All right.
It was late at night. I told him to go to bed instead.
All right, then. Well, certainly, one way we can do this is just unofficially, if you want, just in the chat box, you could just put yes or no, or leave it blank, however you want to do it. And that way we can see, get a kind of a feel for how how everybody is interested, if there's any interest in that or not. If there is, again, we would be happy to coordinate that. And I'll give a few minutes for people if they're interested in doing that and putting that in the chat box. Dr. Pizzino, do you have any ending comments that you would like to make?
No, really, I want to thank everybody. I was watching the level of participation, and we reached the peak of 44 participants, and we are now down to 32, but just in the last couple of minutes, we had 6 or 7 people logged off. And we are almost at time. So my experience with this kind of events is usually you have a lot of people who drop out, especially in a long event like this after the first 30 to 60 minutes. So thank you very much for sticking with us. And I assume your participation is a sign that the information that we presented was of your interest and was relevant. We are getting some input on possible ideas how to move forward. I think probably the best thing we can do at this point is to try it, and if it doesn't work, we will stop. But just I hope you are all receiving our emails. You are on our email list. If not, send us your request and we'll put you on the list. And we will probably organize maybe a 30-minute check-in call sometime the next month or so, and we'll see if there is enough participation to warrant the continuing that idea and concept. But again, thank you, and I hope you will enjoy the rest of your day. And unless there is anything else, I think we can adjourn.
I think so. Thank you, everybody.
Thank you.